Hello. Good morning, everyone. How are you all? Great. I can feel this energy because we need it for this conversation. And let me start with something simple but uncomfortable. Truth that healthcare doesn't fail people miserably. It fails people predictably. Because when culture is missing from the care, what we call non compliance is just misalignment. Representation here is not just about who is in the room, it is about whose knowledge counts, whose lived experience is validated. And I'm incredibly glad that I'm not only the one thinking about this problem. I am Neha, founder of Diaspora Nutrition, and I come from this world of immigrants, of Asian Indians, where I talk about culture forward nutrition for the immigrants on the foreign land so that they don't feel this sudden health decline like food intolerances, metabolic issues, and then you are dismissed by saying, you know what, just quit your rice and have your quinoa instead. No, we are not going to accept that. I want to introduce you to the amazing panel along with me who will be talking on this conversation. Introducing Dr. Frida Maina, CEO and founder of Spiral with Frida. Barima Uwuzu, founder of Ankara Health. Eric Harris, CEO and founder of Canary MedTech. Brianne Kaiser, BetterHelp's director of International Clinical Operations. And Daniel Ruth, founder and principal of Dignity Life. And I want to start with a question that goes right to the root of the cause. Dr. Frida, what decisions are we making before a patient is ever seen that seem correct today, but maybe quietly shaping the mistrust, misdiagnosis, and disengagement later? I love for you to start us off.
Thank you so much. And that's a very good question. And we have many lived experiences and many stories that all of us here could tell where you went to see your doctor, and even before you had a conversation with the doctor, they're already prescribing for you that, you need to take this or you need to start on this. So those are decisions that are already being made right there, real time. And I'm sure if I sampled here, there are many of you asking yourself, where did they get that information to start making decisions to prescribe for me something? Oh no, I looked at your chart, and because you're from this, race or this background or this continent, I know you are more likely than most to get this. And then it's like, okay, so we are going to run some blood work to find out, or we're going to send you to the lab to find out more. And then my question was on that particular day, when I remember that, I was in Michigan. It was a cold day. So I asked, so how did you know, number one, I'm pre-diabetic when you hadn't even had a conversation with me? Just by looking at my chart. So those are decisions that are made pre even meeting the patient. And then when it comes to, oh, this is informed by research that is global. And then it's like, did it include me or people like me? And then no, it was a general research, and that's what we found. But you haven't answered my question. Did it include me? And so what I'm trying to say is, number one, the decisions that are made on medication, the decisions that are made on how we conclude who is, predisposed to get what or to be prescribed for what, the decisions about who is making those decisions, all right? Because that's the question that kept coming to my mind. Who is making these decisions? Am I represented at that table when they're making those decisions? And then when it comes to research, decisions are made, again, on generalized research, which is not specific. And so when you find your doctor telling you, this is what I think is going on, then have a longer conversation with them about why do you think so. So another decision that is made is the space or the time between intake of a patient and the time they see the doctor. So I'll come in at the reception, I'll be given a long form, whether it is on the iPad or a physical form, and as I'm sitting there filling in all this information, even before it gets to the doctor, they've already made a decision about that. But I'm sitting there alone, and I'm filling it, and there's nobody to even ask a question. And so I'm there, the doctor is over there. There's that space. And then guess what? The minute the doctor gets into the room where I've been sent to wait for the doctor, within 15 minutes, they're able to diagnose my life history, my relived experiences, and come up with a diagnosis. 15 minutes. Because another decision was made about those 15 minutes. We are talking efficiency, and so we want to pay the doctor by the fees, not by the time they spend with the patient. And then we want to minimize the time they spend with the patient, and therefore the doctor is caught in between wanting to give proper care to the patient and efficiency. So is it efficiency we are going for, or is it care we are going for? Again, decisions that are made without the power or inclusion of the patient. And yet, we are talking about patient care. So when we're talking about patient care, which happens to be you and I, and we are not at that table, or we are not represented at that table where decisions are being made about us, that is where cultural incompetence and lack of knowledge comes in. And that's where decisions that are made out of speed rather than care. That's where my concern is. I hope I answered that question.
Beautifully, beautifully. And we need more conversation like that. Let's pass it on and continue this.
All right. So, Brima, I have a question for you. So, bearing in mind the space and the speed that I was talking about for patient care, what can AI do? And so, my question is, AI has the potential to reinforce systemic biases. I've highlighted a few biases, if not carefully designed. So how is Ankara Health building its platform to avoid embedding these biases and ensure it actually expands access to care for underrepresented groups like me?
So great question. So great question. And our metabolic health platform, the way we're trying to incorporate cultural competency into it, I'll give an example of garbage data in, garbage data out. When you think about clinical care, one example is with glomerular filtration rate, GFR. For a long time, there was a race multiplier. And so because of that, African American kidney function was overestimated, which led to an undertreatment in terms of kidney disease in the black population. And so knowing these things, there are data tables or our data sets that we're utilizing. We're trying to eliminate some of those different race multipliers and things, and utilizing the historical data, but then also combining it with real world data and evidence from real populations and different segments of populations looking at those different markers. We're looking at mostly metabolic markers, but having an understanding of where the flaws are in the data sets that currently exist are one way. And so from a cultural competency perspective, we're also including the voice of the community. And so I'm based in Michigan, and so there's a lot of community-based organizations in the Detroit area. And one thing I've noticed is that with precision health and with digital health, there are a lot of tools that are being created that don't have the voice of the populations that they're trying to serve involved and included. And so what we've done is connected with these community-based organizations to talk to the community and the people who would be the users as to what they utilize, what things they don't use, how does it fit into their daily work and their daily life cycle, because we're trying to connect with more blue-collar manufacturing workforce populations, whereas a lot of the digital health tools out there are geared towards more affluent clientele. And so there's a disconnect between the target audience and the solutions that are being provided. And so that's one area of how cultural competency and the connection that we're trying to make in terms of getting the people, the end users, their voices to the table, and they can be involved in the architecture and the design of these different tools.
Thank you so much.
Yep. So Eric, I have a question for you. As digital health and is distrust in healthcare really the root issue, or is it the consequence of gaps in representation across data, design, and care delivery, especially as AI becomes more embedded in the system?
Yeah, I think the stories that we're seeing and what you're speaking to alludes to that as, I mean, we think about data and the fact that the decisions are being made before you even have that conversation. And that's something that many of us probably experience regardless of what race, ethnicity, where we're from. We've experienced that where the decisions are being made. With AI specifically, the data set is important because the models are being trained on that data. So if your or my data is not included in that data set, how can it then make a decision that impacts or that actually is relevant to us as patients? And so that is something that we're looking at. And that's a big thing. Distrust is huge. But distrust, I don't think starts at data. It actually starts, like what you said, you're in a physician's office or you're in a clinic, you're filling out paperwork. It's that experience. And oftentimes, how the system is set up currently is not based upon the patient care, it's based upon the outcome of the doctor getting from one patient to the other. And that disconnect is where distrust is often started. Having experience with a family member who went through a similar thing with Liprocel and high blood pressure and was diagnosed, had a lot of symptoms, fatigue, lack of sleep, low energy, and didn't realize that it was the medicine at the point. Stopped the medicine after a couple of weeks, got energy back, etc. Went back to the doctor, the numbers were not quite right. So the doctor said, stay on the medication and let's give you an inhaler because you have shortness of breath. It's like, why are you prescribing yet another thing instead of identifying what might be causing this reaction to happen within this person? And so those are some of the conversations that we had. She stopped cold turkey and said, no, I'm not doing any of that, and was fine. And lo and behold, her blood levels actually regulated normally. And that's just a conversation we had with the doctor versus just prescribe. And so that distrust, I mean, her husband doesn't like, I'm not going to the doctor. It's his response after seeing his wife go through that. Imagine if that happens across a large population. Now they're not engaging when they should, and that data is not there, let alone the experience. And so those things I think we're dealing with now, and that creates a huge distrust, not only in the medical system, but then also in the health system, but also in the data that's coming out of what's considered as personalized medicine as well. And
I'll hold on here. And here I would like to take a quick pulse from the room. As you have listened to the three experts, where either the data is not correctly acquired, either the data is not interpreted properly, and then there is a cultural gap. How many of you in this room have experienced this cultural tension, misunderstanding, affecting the outcome of the patient? I want any one of you, if you have any experience to share or ask.
Yeah. I see a hand at the back. With the lady in red.
It's for the people. We have a live feed, so that's why I asked people to get on the mic. I don't know if this is an example that does justice to what you're looking for. I work in mental health, and when I was working through my license, we worked with people from federal probation who had gotten out of federal prison, and there was a cultural judgment. I'll just try to say it as nicely as possible, where people of African American descent were highly judged negatively, and they dropped out of care. So I'll just say that. I hope that that was helpful.
Thank you. Thank you for sharing this. It might help us to bring more humility in our care, how we approach the medical system, and that's what we are here for. Thank you. Eric, I would like you to continue.
yeah, absolutely. So we were having a conversation out earlier about just access to health and some of the things around accessibility internationally as well. And you're working with Better Health doing that. Can you share a little bit more on when it comes to digital mental health and how to scale that? How do you ensure that access is there and that it's appropriate to, I mean, you have languages, you have barriers in financial. You know, can you share a little bit more what you're doing there and how does that work? How are you solving that problem? You're good.
Okay, thank you. I never know. I think what, from a BetterHelp perspective, is we are recognizing that access alone does not equate to cultural competence. So while we have 30,000 members, we have 30,000 therapists from 100 countries, that alone does not indicate cultural competence. So through our matching system, we recognize that therapeutic alliance is one of the strongest predictors in mental health outcomes, positive mental health outcomes. So we're asking questions like language preferences, we're asking ethnicity, we're asking questions around religious-based perspective, specific conditions. And the idea is that we're having a match rate from a client to a therapist perspective at around 93%. So again, we're asking the questions to kind of be a little bit more grounded in that localized experience, in addition to having 7 localized countries. So while you can be a member in Singapore or in the Philippines and match with a therapist globally according to your preferences, we're also looking at how can we localize more specifically. And that means having country presence, having therapists grounded in that culture, in that context, and having that client experience be a little bit more relevant to your patient care journey. In addition to that, I think it's really important to recognize that therapeutic alliance is a predictor, but so are the specific preferences. How are we talking about care? How is mental health understood locally? What are the stigma parameters? What are those biases that we need to factor in? And that is one of the core values that we see as being the strongest predictor. So I'll pause there and maybe hand it over to Daniel, because while I was speaking from a mental health perspective, Daniel has a lot of experience in senior living. So I would love to hear your perspective on how do we see cultural competence in senior living.
Thank you. Can you hear me?
Yes.
Wonderful. I'm actually, as I was walking up here, I decided to completely change my approach this morning. I've done this before, much to moderator's chagrin. But I think 3 stories in senior living, 2 or 3, will really give you the sense of how cultural competent organizations can thrive or greatly fail in senior living. My background, by the way, is I have designed, developed, and operated Jewish-sponsored senior living communities in Canada and the United States. So the stories, could you imagine you're being flown in for your first interview, and you're walking down the halls and you hear what is an older adult singing, Baruch et Adonai Hamvarach le'olam va'ed, Baruch atah Adonai. She's starting to go through her bat mitzvah. When there's a special rite of passage when one is 13 for boys and girls, bar and bat mitzvah, and with this woman, she was a Holocaust survivor, and so she never had the opportunity as a child to get bat mitzvah. And so at the Jewish Home of San Francisco, we started holding on a monthly basis bar and bat mitzvah. By the way, it takes 6 months to a year to learn as a student of bar bat mitzvah your part, unless you're not worried about screwing it up all the time. I was. By the way, you're supposed to sing it. I purposely didn't sing it today. You don't want me to sing. Okay, so that's sort of the first story. And I happened to poke my head in the room in the synagogue, and it was there was no room for anyone else to join. So I just stuck my head in, and it involved the family. So cultural competency is ensuring presence and representation of major constituent groups of an organization. So at Senior Living, we looked at, of course, our Board of Trustees. We looked at our staff, to be sure, and we looked at our resident population. Which population do you think we did the best job with, and which population do you think we did the worst job with? I'm going to open that up. The three choices are staff, residents, or board. You're boarded? Yes, sir. Board. As which one?
As the one not represented.
The choices are staff, residents, or the board.
Or the board.
That's the board.
And my question was, who do you think we did an extremely good job with in terms of, and which one do you think?
I'm saying the board you did a good job with. The staff was second and the residents were third.
You're wrong on all accounts. How's that? The board did a fabulous job in terms of taking the perspective of the staff. But when you looked at the actual representation of the board, it was 100% Jewish. That was not representative of the resident population we were looking after, and it certainly wasn't representative of the population in near proximity. So the board took themselves very seriously, maybe too seriously, and they did not apply the same rules to them that they were applying to the other two groups. Your second one was staff, which you thought, you listed board, staff, and, correct? And then residents.
No, my response was data, we only analyze what we look at.
Right.
So the more data you have, the more you look at it. Since board tend to be more outspoken, they're usually listened to first. Staff is second, patients are third. I'm not saying that's what it should be.
You know, you're right. And in fact, I think staff or the staff group are right there with the board in terms of significance and importance. And we did a horrible job of really integrating and involving staff in key decision making. It got a little bit better, but it took some time. Those are my couple stories. I think I'll stop for now.
Thank you. Thank you so much. I would like to open up to the audience once again. Yes, for those who have any questions, can we hand over the mic? We're all decision makers here, so let's work it out.
Good morning. Can you hear me?
Yes.
Yep.
Oh, okay. Yes. When it comes to cultural competency, in my experience, I found that one of the barriers is more on a systemic level. I feel like those in leadership positions who do hiring and things like that, maybe gatekeepers, if you will, cause issues with allowing certain individuals that represent certain cultures in the door. And in mental health, we have a large proportion of clients that are not being served because they can't connect. And engagement is a big piece of the work that we do. So I'd like to encourage us all here as professionals and leaders to be cognizant of the biases that we hold at the door, because if we're not, I guarantee you that's being perpetrated on the people that we're here to serve.
Well said.
So well said.
Mhm.
And I would like to also add on that we are one country, right? We are all here together owning our life to the soil. So let's bring in that diversity and inclusivity without any biases. Anyone else? Yes, sir.
Can you hear me?
Yes, I can.
So my question is, why are we diagnosing one person? Because if you haven't done research on a certain group, how do you know, like for example, the medication they give to people that have diabetes, they give it to everybody, and they haven't done research on all of different groups or race, how it reacts to the person. So a lot of my friends who are black but they have diabetes, what they have complained to me is that the medication makes them feel sick. So therefore, that is why they do not like to take it. But I think there is an assumption that because most black people don't take the medication, it's like we are rebelling or we don't trust the doctor or something. Because when I speak to my doctor about certain things, she's telling me your cholesterol is high, blah, blah, blah.
Absolutely.
Well, you haven't even, when you take the blood test, the result was not in, but you already wrote me a prescription. So that is where I argue with them and I say, well, how are you sure what is going on? Because you already assume that I have diabetes and I have cholesterol. And the results are not even in my blood results.
Can I?
Absolutely. I think, is there somebody
Yeah,
inside the
I,
healthcare
I
system
would do
who
that.
can answer that?
So there's one aspect of that that we all should consider. Medicine is science. Science is experimentation. It's a hypothesis, and then you test the hypothesis to see whether you're right or wrong. Most doctors, they're scientists in nature. That's what medicine is. So if we go in uninformed, the doctor's starting at a place to then figure out where to take you to or from. And that's just medicine in general. So it's not that I mean, some people are incentivized to give out medicine because they make money on it, sure. But largely, many times, doctors are, especially if you're a new patient, they're trying to find a baseline to then understand where are you going based upon where they see your symptoms arising. But that's the onus on us as people as well. Own your data. Understand your own health data so that you're informed of why your cholesterol numbers are the way they are based upon your activity levels, your diet, your nutrition, things of that nature. The more informed you are, the better you can actually answer questions when you're asked. And that also gives you the power to then negotiate how you are going to be experimented with. You're taking someone that is highly trained in experimenting and understanding medicine, but it may not be relevant to you. You bring that information to help them tailor their experimentation or hypothesis process to give you personalized care. That's our responsibility, regardless of who you are. That's our responsibility because ultimately it's your body. So that's something to encourage as well.
Can I?
So-
Sorry.
I would like,
I just want to give it like the flip side. And while I think the responsibility should be as you are your best advocate as a patient, as a client in the healthcare system. But at the same time, assuming that everyone has the ability to synthesize the data and have access to that education and knowledge, I don't know if that's necessarily always the responsibility of the patient to have that informed decision making. So to go back to your question, on combination of self-advocacy, but also embedding some of these cultural competencies learnings, that it's not a one-size-fits-all approach. We're acting and we're starting with a treatment plan as a baseline, but when those cultural considerations and perceptions come into play, as well as physiology and science and all the rest, I think that's where we see a better healthcare system writ large.
Yes. And I would agree with that. Yes. There's a caveat
would
to
you
that.
like to add something into
Yeah,
it?
so I was going to add into your point about diabetic medication and having spent a lot of time with clinical trials and clinical trial involvement. To your point, it's experimentation. And so if you think of it as a bell curve, when you're doing studies, the medication is geared towards the majority of the population, but that again goes to data going into it. And so people being involved in the clinical trials from the beginning helps understand which populations may benefit. So unfortunately, there's a lower incidence of African American people in joining in some of these studies. And so you're already removing the population at the onset. And so just being mindful that no medication works for everyone, but the goal is medication should work for the majority of the population. Side effects are part of the process because, again, it's a risk-benefit scenario. You understand that you're accepting some risk with the potential that you'll have more benefit than risk with certain medications. So as a pharmacist by training, I actually err on the other side that I try to tell everyone go the holistic route if you can, and if you can't, because it requires more work in terms of habit changing and habit modification, then use medication if you can. But again, to some of the earlier conversations, there's so many ways that you can naturally improve when we talk about chronic diseases such as diabetes, hypertension, those sort of things, that you should approach those routes. Because if you look at most of the studies, background is always diet and exercise and lifestyle modification first, with medication on top of that. But most people don't do the underlying steps.
Yeah, that's true.
Dr. Frida?
Yes, so thank you. And what I wanted to piggyback on is the advocacy, component, and, you taking charge. But then I do remember there is power dynamics. So, and then because of the cultural incompetence we were talking about, when it comes to power dynamics, there is that assumption from some cultures that the person who knows, or the person I'm going to consult, is going to do, number one, their due diligence because they know better. That's the assumption I'm coming in with, even as I am ready to advocate for myself. And then when you go to a person who now knows more than you do in that field, not about me, they don't know me, but they know more in that field, then I go to them and I drop my power. And I give them all my power because they will do their diligence and because they know. That's the assumption in the hypothesis, right?
Yeah.
So because of that, then as much as I want to be my own advocate, I'm already disempowered because the person that I have gone to consult is supposed to be the person who is in power. Just like a teacher, I've been an educator since I was 19. Just like a teacher, when a student comes to a teacher, they're coming because, oh, the teacher knows more. And then you realize, I don't do math because I don't know math, right? My children are always laughing at me because when they give me 5 quarters, don't ask me how much money that is because I have no clue. I know that 1 quarter, there are 5, but the result of that, I do not know. So anyways, so the power dynamics, and let's go back with that power all the way to the boardroom, all the way to the research department, all the way to the trials. And then the conversation we were having about, the data that is collected. And so, like you said, if the bell curve is like this, then they'll follow the majority of it. And then, unfortunately, every time I'm falling on the outlier section. Therefore, none of my data is making it to the boardroom or to the clinical trial decision or to whatever decision table exists. Because, number one, when it comes to access, I don't have access. When it comes to financial, so that I can pay even copay, not on that table. When it comes to diet and exercise, I can't even afford because I live in a food desert. So all those outliers, I will never make it to the decision table. And then I become my own self-advocate, and then I have no power because I have been disempowered by the fact of the power dynamics. So tell me now, because we are all here, what are we going to do about that? Yes.
Take down the patriarchy.
Yes, ma'am, please. You want the mic? Yeah, you. Yeah.
So we all know that data is only as good as the question that asks it. And in virtual care, and we spoke about. Is it on?
Yeah, it's better.
Here it is.
All right, so if you can hear me now, I'll repeat. So we all know that
Hold
data
it closer.
is
There
only
you go.
as good as the question that asks it. And in intake, or when we do virtual and digital models of care, we need to ask the right questions for efficiency. We are now in an area where, to understand diversity and to be inclusive, we inadvertently created boxes that go into those questions. Do you think AI is allowing for those open-ended questions to come back? I find myself always putting other. So where does that potential live in getting the accurate, inclusive data?
Fabulous. Any AI-driven.
I can have somebody in the audience speak.
I see someone else over there.
Yeah. I
Oh,
have a
there's
thought.
someone else.
By the way, I did clinical trials or designed and ran clinical trials for 42 years. And everything you're saying about clinical trials is true. Clinical trials actually do not gather sufficient data. For example, you mentioned EGFR. It is an assumption, not a test. One of the problems that the medical community has, or the world has about medicine, is we're guessing all the time.
Yep.
We really don't have the data. AI will not solve it because the AI doesn't have the data.
Correct.
So the bias the medical community has may not be intentional or racial or sexual. It's that it's ignorant and it's trying to use heuristics or rules of thumb to try to treat without data. One of the things that the research community is looking at is things like how do we get more data? And we know that the Mag 7 have lots of data on us to manipulate us. The medical community has almost no data on us. What you advocate about your data, absolutely agree. The whole question is how do we get more data? And that's biometric, biomarker, imaging, and we really don't have enough data, so the physician or the treater guesses, and they guess based on their bias. Without data, we can't change.
Okay, just want to make sure that we respond to the question that was asked first.
Yeah.
And I'm
So-
not sure how this,
Yeah.
we're just going to fix it. Thank you. So I apologize for that.
So what he said actually does address that question because it's showing holistically how the system. So your question was, can AI kind of unlock or get us back to that point? And the answer is no, because the AI is already fundamentally built on a lack of data. The data is not available for AI to also access to then unlock more of. It can poke holes at it, but there's a bias in that in and of itself. If we understand some of those root systematic things, we then can start to ask better questions based upon what we already know. We already know there's a lack of data. How are you contributing to getting more data for yourself? Are you resistant to wearing a smartwatch or going in for blood pressure or whatever on a routine basis? How are you tracking and doing things for yourself to give yourself an additional data point that helps you then understand at least what's going on in your own body? If we start to do those things as individuals and advocate for more people to do your bare minimum, do your basic due diligence on yourself, even if you don't, to your point, understand everything. If you could go in, and I've seen this happen before, someone started taking their blood pressure for 3 weeks, knowing they were going to the doctor. They took that information into the doctor. The doctor then did not prescribe something, not because they didn't need it, because the doctor saw they were handling their blood pressure okay. They had a good management program. If you don't have the data, the doctor has nothing to go off of, the doctor guesses, the doctor puts you on something because the doctor needs to have something to start with. If we give the doctors or give physicians or give people more information in that capacity that you own, it could help in having that conversation of what am I doing, where am I going wrong, what do I need to adjust? But if you're not tracking anything, what doesn't get measured doesn't get changed.
Mm-hmm. And so adding on to that, the analogy I like to use is, think of finances. That's something that we track every purchase, every expense, and you can see the trends over time. And to that point, if you do the same with your health, again, now you're looking at more complete trends. Most people go to the doctor, if you don't have any conditions, once a year, maybe twice a year, and they're getting a snapshot in time with no concept of what else happened throughout the year in terms of your lifestyle, nutrition, physical activity, all of those different factors. And so if the doctor is able to have more information, or you yourself are able to have more information, now you can make you have a more complete picture of what's actually going on and be able to guide care in the right direction.
Mm-hmm. Absolutely.
Thank you. Thank you. Is that answers your question? Yeah?
Slightly.
You want one last? All right. Yes, perfect. Yeah.
Okay, so as a 30-plus year internist who then switched to the other side so I could empower people to know their numbers, I can tell you that it's very hard in a 15-minute visit to get all of that done. And so what I really would love to see medicine doing is focusing on how to empower the patient outside of the room. We're talking about public health focusing on prevention in a true way, not prevention that brings you back to pharmacology, but prevention that frees you from it. And how do we then teach people that if you really understand the physiology of the human body, in the easiest way you can, because we can't teach everyone how to understand. The reason I say this, if you go back to the indigenous, in any culture, they figured out how to live healthy in their culture. You go to Australia. The indigenous learned how to eat poisoned food. If you don't know how to cook it like they do, you will die. But they thrive. And so we have to teach people to remember their power. Remember the fact that whatever culture you came from, I happen to be Jamaican, you can learn from your culture how to take care of your body.
Perfectly explained, and I would like to close down this here by telling you one thing. As she mentioned, there is actually a system problem right from the basics, because in America the food is seen as this isolated groups of carbs, proteins, and fats. And then if you want, you need a fortification of some iron, fortification of B12. It doesn't work like that. Our body is so complex. But indigenous cultures, they already know, because there the system has not been developed inside a lab. There the system has been developed by observing the nature right through 7,000 years, and it has been passed down not as certifications but as oral traditions, right? So the one key takeaway here is, from our part, is to be culturally rooted. And the people who have lost their culture, what they can do is that they can bring those experts. Don't make Ayurveda or traditional Chinese medicine, herbalism, as an alternative medicine. It's not, it's the OG. Bring it together in the boardrooms, create the system together. The mainstream needs the cultural background. Without that, we'll continue to fail, and we will be there in that circle again and again. What medicines to give, how much questions to ask, this and that. It won't work unless all of us don't come together right from the basics to the most advanced medical system in the hospital. Thank you so much for all of us, all the experts here, and all the beautiful audiences. Thank you.